So the study I'm going to be talking about is called the STAR trial. And the background for this is in renal cancer, many patients are treated with tyrosine kinase inhibitors or TKIs. And the standard treatment is to continue treatment and usually until disease progression on radiology, or because of toxicity that the patients need to come off. And some patients can be on treatment for a long time without a break. It can be years for some patients and usually often months. And so the rationale behind the trial was, could we give treatment breaks to patients so that they would have less toxicity when they were on a break, without compromising survival and quality of life, comparing that to the standard way of giving it. And the other factor here is, these agents are not inexpensive. And so it may also provide cost savings with the treatment breaks. And it may also be that because of the break, you less likely to develop resistance to these particular agents. So that was the rationale behind the study. So with this particular study, I know there've been other intermittent trials with tyrosine kinase inhibitors in kidney cancer. What was different about this particular trial was that it was a fully randomized study, and it was a run-in phase 2, going into a phase 3, and the numbers from the phase 2 counted as part of the phase 3, so maximizing the input from patients. So the phase 2 part of the trial looked at ease of recruiting, because when this trial was conceived, it wasn't by no means a given that patients would want to have treatment breaks. They might be worried about being off treatment, and also clinicians might not want to stop treatment. So the first bit was looking at 14 UK centres, looking at was it actually feasible to recruit the patients at the required rate, and looking at some early efficacy signals, so that the time to what we call strategy failure wasn't very significantly different in the phase 2 trial. And fortunately that was the case, and we got the signal to then carry on to the phase 3. And what was important about this trial is it had co-primary endpoints, which is actually quite unusual. So we were able to look at qualities, to look at quality of life and economic considerations, as well as overall survival as co-primary endpoints. So that was a fairly unique and a sort of an exemplar trial for the NHS. And obviously it's unusual to incorporate those two particular components. The trial design was that patients would all be randomized at baseline, and then they would have standard treatment with initially sunitinib, but then as pazopanib became available, also with pazopanib for 24 weeks, or what we call 4 cycles of treatment. And then they would take up their randomization, which was in the continuous arm, was to continue standard schedule, whether that was 4 weeks of sunitinib and 2 weeks off, or continuous pazopanib, which was to take daily. And they were allowed the standard dose reductions as per the SPC. In the experimental arm, patients at 24 weeks who had not progressed on treatment or already come off treatment took up their randomization of a treatment break and were monitored by CT scans every 12 weeks, and only went back on treatment when there was resist progression. It was mandated that all patients would have at least one treatment break, but also if patients wanted to and local investigators were happy for them to do so, they could take up multiple. And indeed, about 42% had 2 or more treatment breaks. And this was a 60 centre, 920 patient randomized study. So as far as I'm aware of, the largest academic study looking at treatment breaks or treatment holidays ever carried out in renal cancer. I think the other thing was that it was particularly useful study, as it didn't just involve what you would call the ivory towers centres. We also involved a lot of, because it was a very pragmatic trial using agents that were already standardly available. and was easy to include patients in. We're able to include lots of smaller centres and really kind of set up that research network for renal cancer trials in the UK. And really these 60 centres are often, you know, the length and breadth of the UK, England, Wales, Scotland, Northern Ireland. So in the ESMO presentation, I'm just concentrating on the phase 3 endpoints for this particular study. As I say, 920 patients actually took up their randomization as part of the trial. We were able to show as part of the trial that the baseline characteristics for the patients, they were well matched between the two groups, and the age reflected, perhaps more than the original registration trials, the sort of a real world population in this patient group where these agents were already standardly used, and a significant number of not just PS0 but PS1 patients. So a fairly representative population of the UK population. So as we say, we found that, you know, at least 43% in the intermittent arm had more than one treatment break, and the maximum was actually 9 treatment breaks, with significant numbers having 6 to 9. In terms of the primary endpoint, Dava, if we look at overall survival for the ITT population, we were able to show no non-inferiority. For the per protocol patient, this was very narrowly missed. If we're looking at it very sort of robustly, but if looking at the Cox regression curves, they're completely overlap. So as a clinician, there's absolutely no difference looking at those curves really between survival times between the intermittent strategy and the continuous strategy, giving confidence in patients adopting the intermittent strategy going forward. I would say that because, and it's a good thing, survival has slightly improved in renal cancer while we've been doing the study, and we weren't quite able to reach the power of 80% for the study. It was 0.77. And although the confidence interval was narrowly missed by the per protocol population, where it of 0.812, this is probably reflected in that number. So basically, we were able to show overall survival was non-inferior for the ITT population and very, very narrowly missed for the per protocol population, but the Cox curves overlap. And, you know, so from a clinical point of view, I can't show you the curves actually on this, but from the ESMO presentation, you'll see that they're completely overlapping. So if we then look at the forest plots for overall survival, we can see that whichever group you take, the findings are the same throughout. So if we look at Moixer score or IMDC score or the type of TKI used, whether pazopanib or sunitinib, the findings are the same. So there's not one subgroup that particularly is disadvantaged by the treatment break from the data we have, and it's from the survival a safe option for patients. If we look at then the other co-primary endpoint for the QALYs, this was met in terms of non-inferiority for the per patient and the ITT population, and indeed the per protocol population was actually superior in terms of QALYs, which you might expect because these patients on a treatment break were having less toxicity, and indeed when we look at the serious events data, we see that there were less attributable toxicity events due to drug in the intermittent arm. In this trial, and obviously I would refer you to the ESMO slides, it wasn't really appropriate to also use time to progression as a secondary endpoint, because in the intermittent arm, by definition, they have to have progressed to go on treatment. So prospectively, we set up two particular endpoints to allow for this, something called time to strategy failure. So basically that meant if you were on the continuous arm, it was when you progressed according to RESIST on treatment or time to death or new systemic therapy. For the intermittent arm, it meant time to progress with the same, but actually on treatment. So you had to actually be back on treatment and progressing for that to be a progression event. And that's why we use the term time to strategy failure. And that was markedly better in the disease-free interval arm, also reinforcing the belief that these patients, it wasn't like if you took them on treatment, they then were unable to respond to therapy. They either had, they were able to re-respond and have further responses. The other thing we looked at is summative progression-free survival, which again is a marker of these patients re-responding on re-challenging after a treatment break. And again, this was much greater in the DFIS arm, and the time to strategy failure. So what that means is the time from starting sunitinib or pazopanib, if you include the treatment breaks and time on, was significantly longer in the intermittent arm. So patients were getting more out of that particular strategy. So I think they were the main findings. So in conclusion, it was the largest randomized study of treatment breaks that I'm aware of in kidney cancer in an academic study. And we were able to show that treatment breaks were acceptable to patients and clinicians, which was something when this trial was designed, which certainly wasn't known. And we are aware of that because of this study. They were not detrimental, the breaks, to overall survival, and not detrimental to quality of life. And again, for the PP population, there were some improvements in the quality of life in the group, and also there was significant cost savings using the intermittent strategy. So in the future, we're going to be doing an additional analysis looking at the quality of life in more detail, but also looking at patients, what were the characteristics of those who benefited from multiple treatment breaks, and tease that out a little bit more as a pre-specified analysis. But I just wanted to put this into current context. So although immunotherapy or immunotherapy with TKI is now standard treatment for significant numbers of patients first line, TKI therapy still remains an option for many first line, and if not first line, for significant numbers second line. So I think these findings are relevant, and I think they also should be seen of as an exemplar trial to look at the same type of questions in newer therapies. If patients on a TKI and immunotherapy, would it also be sensible to stop TKI and immunotherapy and have treatment breaks accordingly, because all of these agents have cost and they do have toxicity. So I think we've already seen from other trials in design that one of the other legacies of this trial is to, help take that sort of intermittent strategy forward and ask the question also with other agents and other cancers. I think they can give clinicians confidence who are treating patients with TKIs that treatment breaks are acceptable and safe, because when you reintroduce treatment, patients re-respond. I think, from a health service systems, who they also are saving in terms of resource, but also what we found is the patients actually like the treatment breaks, whether it's to have holiday or have a break from toxicity. And interestingly, in the COVID, I think it's become even more important because it saves hospital visits, which is also appreciated by patients, and less frequent blood tests. I would think the legacy would be, and obviously we've got further cost analysis to do, that for patients treated with TKIs, I would hope this could become part of standard treatment, because it was a very large randomized study. And I would also hope the lessons learned could be extended to other newer combinations such as IO and TKI. And finally, I'd like to thank everyone who made this study possible, but particularly the patients and their carers who took part in the study. I'm very grateful for them for having done so. Thank you.